Thank you very much. And so I am the founder and executive director of Indiana NOFAS. We are affiliate of NOFAS National in Washington, and I'm also a subsidiary of Mental Health America of Indiana, whose office is located in Indianapolis. I was a foster parent for the state of Indiana for 12 years, and we adopted 9 children from the foster system, 5 of which had prenatal alcohol exposure. So my expertise is both on the technical side and then also on the lived experience side. And let's just jump right in with the material that we have here today. FASD is not a diagnosis, it's an umbrella term, similar to what we see with our autism umbrella. And it relates to all the disorders that are underneath this umbrella that can be physical, mental, behavioral, and often include some learning disabilities with lifetime complications. Underneath that umbrella, what is the most well-known but the least diagnosed is fetal alcohol syndrome, or FAS. And this isn't diagnosed as frequently for a couple of reasons we're going to go through here. This requires that there is evidence of prenatal alcohol exposure. And on this particular slide, when we're talking about evidence, we're talking about a biological parent saying, yes, I consumed alcohol. We also have to have evidence that the central nervous system has been structurally or functionally damaged. Now, when we go through the process of getting a diagnosis, oftentimes individuals have an MRI, and the physician comes back and he says, oh, the brain looks good, everything looks wonderful. So sometimes the damage to the structure is so minute that it's not picked up on an MRI when it comes to the structure, but we see that damage on the functional side with regard to challenges in behavior, cognitive challenges. And it also requires the presence of facial features, which we call phenotypes. We're going to see what we're talking about on the next slide. Often these individuals have pre or postnatal deficits. They can be a little bit smaller. Their head circumference can be smaller. Often are tagged with failure to thrive. These are the phenotypes that we were talking about. And let's just go through them one at a time. The first one we want to talk about is this opening here with their eyes. It's a little bit smaller than what we would expect to see in a typical peer. The area under here is called the philtrum. When you put your finger underneath your nose, there's likely you're going to feel some ridging underneath your nose. Her area here is smooth or flat. We have a thin upper lip. If you look at the difference between her upper lip and her lower lip, you can see that her upper lip is thinner. Before we leave this slide, these are the 3 main phenotypes. And these are the ones when someone says they don't look like they have FAS, this is what they're talking about. But also on the facial features. If you look right here, right above her nose, most of us have a ridge with our nose. Hers is flat across here. And the space between her eyes is wider. This area up here tends to be a little bit flatter. And if she were to pull her bangs up right now, it would look like that she had a high hairline. On the side of her face, it's not uncommon for the ears to be set just a little bit lower. Sometimes we're going to see a little crease here in the lobe, and maybe on the inside of the cartilage here, where we have little folds that help with our hearing, they may be minus those folds, or we might even see some cauliflowering up here. And those are all related to prenatal alcohol exposure and what we refer to as phenotypes. Those phenotypes are set during days 19 and 21 of gestation. That's a very narrow window. So we could have prenatal alcohol exposure before that or after that, and we wouldn't see those phenotypes no matter how much alcohol is consumed. So when we talk about it being hard to get this diagnosis of FAS, remember we have to have an admission of a biological parent that says alcohol was used, and we have to have these phenotypes with this very narrow window. We also have partial FAS underneath this umbrella. And this includes all of the things that we talked about before. Here, the evidence that is required is not the biological parent saying that alcohol was used, but it can be a credible partner or what they consider a credible witness. So if the biological parent is in treatment, a family member, a partner, a police officer, a DCS worker, someone who would have access to that history says, yes, we know that alcohol was used, here that can count toward our evidence in getting the diagnosis of partial fetal alcohol syndrome. And it does have many, but not all, or as severe of the characteristics as full FAS. But by and large, this is where most of the individuals on the spectrum reside, with alcohol-related neurodevelopmental disorders. And here the evidence is not referring to a biological parent saying yes or a credible witness. This evidence here is that we can see that their central nervous system has been damaged, either structurally or functionally. But remember, most of this is going to be on the functional side because that MRI is not going to show any slight malformations or deficits. And we know that our function has been compromised because we start looking at their scattered skills. When we talk about complex patterns, what we're referring to is those scattered skills, where they may be way ahead in certain milestones, slightly close to some, or woefully behind in others. And I used my son, Zeb, here as an example. When he was 18 months old, Zeb loved to put together jigsaw puzzles. And these aren't the kid jigsaw puzzles or the wooden board puzzles. He would put together 300-piece jigsaw puzzles. He would get bored with those jigsaw puzzles and he'd flip them over and he'd put them together on the backside without the picture. Now, mainstream would say, if he can put together a 300-piece jigsaw puzzle, then he should be able to do that. And they would generalize. That's not true with people with prenatal alcohol exposure. Zeb is now 12, and this is the first year that Zeb has tied his shoes a percentage of the time and is managing his zippers and those buttons on jeans. Prior to that, I was still helping with those things. Here we don't have those phenotypes. We don't have the growth deficits. And so they appear as if they're typical peers. This is highly problematic for them because if you lined up 6 kiddos and they all looked the same, we would expect the same abilities or the same behaviors, the same accomplishments from those 6, and it would be dependent upon their age. Whereas with prenatal alcohol exposure, the problems are on the inside where we can't see. Another disorder here is alcohol-related birth defects. And these are actually physical things that we can see on the body. So it's not uncommon for them to have heart murmurs or a leaky heart valve, some issues with their bones. And this is a little bit challenging to define because it's kind of all across the board. We see a lot of double jointedness. We see a lot of the joints being larger than what we would see in a typical peer. Bones being at slightly awkward angles. We see issues with immune systems. And but we don't see this diagnosis given without a diagnosis of FAS. And the last thing on this umbrella is this neurobehavioral disorder associated with prenatal alcohol exposure. So the 4 things that we have talked about before are on the physical side. This is on the mental health side. This showed up in the DSM-5 a few years back, and we had providers who had clients that weren't making progress with the standardized treatment plans. And they're wondering what about this population of people creates this challenge with seeing improvement? And they were able to determine a common thing between them all was prenatal alcohol exposure. So we can get a diagnosis on the physical side. We can also get a diagnosis on the mental health side. And when we talk about getting a diagnosis, it's recommended that we do this through a multidisciplinary teams, which would include usually a pediatrician, a developmental pediatrician, an OT, and a behavior specialist. And they would be in one location. The individual would come in, history would be taken. They would each have an opportunity to perform any assessments or any physical exams. They would get together after each had had an opportunity to meet with the individual and make a decision as a team. However, this is highly problematic for most states, and especially Indiana, because we don't have these multidisciplinary teams available for diagnosis. And so the CDC, along with the AAP, developed a free online toolkit that any provider, GP, doesn't have to be a specialist, nurse practitioners, can use this toolkit to make this diagnosis. What we learned is that if it's obvious following this toolkit, that it was useful. However, if it wasn't obvious, it was cumbersome and problematic, and so they would still continue to refer out. And by problematic, what we mean is if they're looking at a single behavior and it could be caused by more than one thing, they would say, well, it's not obvious that it's prenatal alcohol exposure. I'm not sure. Am I seeing this because of the alcohol, or am I seeing this because of whatever they suspect is the other contributing factor? And so therefore it was cumbersome for them. And they tended to refer out to geneticists. And then our geneticists got kind of backed up and bombarded. And so in the state of Indiana, most referrals are made to Riley Child Developmental Center or Peyton Manning's Children's Hospital. And there are a very few individuals making diagnosis scattered throughout the state.
Hi there, my name's Kelly. I work for a mental health agency in Johnson County. I just wanted to clarify what you're suggesting. Oftentimes, like you mentioned, in mental health, we see kiddos that just are not responding to interventions, et cetera, over time. And then when it comes out that there was a history or there was FAS question mark, that might explain some of this lack of response to treatment, you're saying to kind of start with, because that's where we come into a roadblock. That's not our specialty. You know, if you're not consulting with the pediatrician, you're saying use the online toolkit, use that as a guide, and then the places to do the diagnosis or testing for further would be Riley or Peyton Manning.
I think the toolkit could be helpful to you. I think that from my understanding, and I'm so glad you're on this call, it really helps to have the real life perspective, because what we are told is that mental health practitioners can make this diagnosis on the DSM side on their own without referral out. But if that's not going to happen, then I think that the toolkit could be very helpful. And then the diagnosis can be made that way. And then if there's still some uncertainty, then I think a referral could be made to either Peyton Manning or Riley, or depending on where the family is living. We have places like Cincinnati Children's Hospital also makes this diagnosis. They're the Triangle Research Center in Chicago also makes this diagnosis. Toledo has a place. So depending upon where our families are located, sometimes we can make a referral outside of the state. And we're hoping that with, as a result of COVID and the telehealth, that we're going to be able to get diagnosis virtually. They're really working on making that accessible to families because the wait is 9 to 12 months before they ever get in. Kelly, was that helpful, or does that still kind of muddy the waters?
No, that's helpful. And we have, I'm not a master's level clinician, so I'm not sure if they can diagnose that or not. And then we also have HSPPs and psychologists that we staff with, and we have internal psych testing as well that we could probably, I'm sure there's some sort of assessment on their end that could rule this out as well. We want to link them to the more appropriate services down the road that, you know, might help them long-term.
Mm-hmm. We have a short amount of time together, so we could chat further or connect offline. But I will say that sometimes, like from a family member standpoint, I so appreciate you wanting them to get linked to someone they think could have the long-term more benefits for the family. But when no one is making that diagnosis, the family gets bounced because. And from your perspective, we're linking them with someone they're going to get more services from, who have access to more resources, who can follow them longer. But then sometimes they are not making that diagnosis. And so the family's going back and forth to multiple disciplines and no one's making that diagnosis, which is problematic because then they're not getting the appropriate services that could be helpful. So I'm showing this slide. I know it's really hard to see, but I want to throw this up here because when we look at where we spend our money in prevention, we spend a lot of prevention dollars on our substances that are considered to be illegal. And that would start with the marijuana column and move to the right. And whereas when alcohol and nicotine are legal substances, we can buy those at gas stations, grocery stores, etc. And when we look at the short-term and the long-term effects, we see that it is our legal substances that have the most damaging long-term effects. So we do expect to see some changes in the marijuana column. We've seen some studies that have come out. We're waiting till there's more studies to reinforce the findings. And we are expecting to see some change in the opioid column. The problem with the opioid column is we have not yet been able to follow these kids who had exposure from birth to school age to span time to see what is that long-term effect. And I apologize for the noise you heard behind me. I have a teenager who's entering and exiting the building. So the risk factors for an FASD is the amount of alcohol use does increase the risks. Now, that's not to say that the getting an FASD is solely dependent upon the alcohol, because everyone is in agreement. The AAP, ACOG, the Surgeon General, everyone is in agreement that there is no 100% of safe amount of alcohol that we can use during pregnancy. But the more that we risk it, the greater the chance is that we're going to have one. The timing of the alcohol exposure is critical. In that first trimester, when things are first beginning and splitting off, if one of those cells is damaged early, then as it's multiplying and moves on, it's going to carry that damage with it along the way. And then the third trimester, when that prefrontal cortex is forming, this can also be a very risky time for problems. The genetics of both the mother and the father, general health of the mom, nutrition, social determinants of health. And with those things, I just want to kind of lump them together for time purposes. here we're referring to if mom's body is having to spend energy and attention addressing any one of those risk factors, that means that there's less energy being able to balance the effects of the prenatal alcohol exposure. And then if there's a prior diagnosis of FASD within the family, and that's not grandmother, this is if with biological mom, if there's another child who's got a diagnosis of FASD, that increases the risk that subsequent children will also have an FASD. And how do we know that we're looking at somebody who might have prenatal alcohol exposure? That inconsistent development, we talked a little bit earlier about those scattered skills. If we see that there's some challenges with learning, of them being able to pick up skills, poor impulse control, I really can't say enough about this except to say this is squirrel on steroids. This is, they see to the end of their nose. So we can practice with them. They can tell you what the rule is. They can tell you what the procedure is. They can tell you what's supposed to happen. And then as soon as they're distracted by something else, boom, they're gone, and they have forgotten their plan. What was going to happen? What was I going to do if this did happen? It's just simply gone. Deficiency in higher learning. Here we're talking about when we get to the stage of double-digit addition, subtraction, the memorization of facts. When we talk about studying words and their meanings, things that they can't put their hands on, this becomes an issue. We see some gaps here that start to widen between them and their peers. They tend to have challenges with abstract. They're very rigid thinkers, very black and white thinkers. Often they come to conclusions about how the world is going to be in their head before we ever know that they're thinking that way. This is a challenge for them with idioms. When I was growing up, if my parents wanted me to hurry up, they would say, you know, light a fire under it. And I know that meant to hurry up or put a sock in it if they wanted me to be quiet. These individuals struggle with those idioms because they're those literal thinkers, and they would be more than happy to help you light a fire under it, but they're going to be wanting to know what it is that you want set on fire, and do they get to borrow your lighter or matches? This also can come into play with money. What does money really represent, and how do I spend it? And as long as you have a debit card, then you can't need money, right? Or the passage of time. What does 5 minutes passing feel like? Problems with memory is two-pronged. It's problems with short-term memory. Most of our systems are set up where a skill is introduced, they have a chance to practice, and then we add to that skill, and then we move on, and we just keep building, building, building. But for them, they don't get to practice that skill long enough to transfer it from short-term to long-term. So what this looks like in a classroom is one day the student knows that 2 + 2 is 4. The next day they're looking at that same exact problem. And not only have they forgotten that 2 + 2 = 4, they don't even know what that addition sign represents or what it looks like for them. Also with the memory, it's how they file things. So adults who have an FASD tell us that their brain feels like Swiss cheese, that they know they put it in there, but when they went to find it, they couldn't find it, or it feels like a sieve. I put it in there and now it's gone. Sensory integration issues. This is going to sound pretty familiar to us. This can be as simple as how things feel on their skin, or being easily overstimulated, loud noises, bright lights, sirens. This can be those individuals who don't want to be touched or touch anything, don't want to get their hands dirty, to the other end of the continuum where they have to touch, feel, squeeze everything. The kiddos that go through a store and have to touch every tag that's hanging on clothing items or everything that's on a shelf. This has to do with being easily overstimulated with smells and how things feel in their mouth even. Tend to like things that are tart, crunchy, that can stimulate their taste buds, but those things right there in the middle, you know, your puddings, your yogurts, your applesauce, your mashed potatoes, those kinds of things, not really sure what to do with that, how that feels in their mouth, and they're uncomfortable with those things. If you've been in an elementary school room lately, when you walk in, you see that the teacher has things there to engage the students. There's posters everywhere, there's objects everywhere. Some of our children who walk into rooms, they're just walking in. Class is not even started yet, and they're just overstimulated by everything that's around them. We share that with our autistic friends. So the next two things we're going to kind of talk about together: auditory disorders and motor planning disorders. And here we're not talking about the individuals that we know have a hearing challenge. Here we're talking about the individuals that their hearing tests come back fine, yet we know that they're still receiving a broken message. So they pick up at about every third or fourth word. This is, again, going back to an example in a classroom. You know, they're sitting in the classroom and the teacher is saying to them, put away your math book and get out your English paper. They're picking up every third or fourth word. So they're sitting there thinking, what did she say? What am I supposed to do next? And it's taking a little bit longer. And what usually happens is at some point the teacher notices that they have not complied yet, and will repeat the same exact instruction, thinking that A, they didn't hear, and B, that they're being helpful. But what happened for this individual is now they have two messages stacked on top of each other because they don't recognize that it's the same message. So they look around and they're really good at picking up survival skills. So they're going to look around at their peers. What is everybody else doing? What do I need to be doing? And so then their brain has to tell their body what it needs to do to comply with this instruction. So for you and I, we'd be sitting here thinking, I need my pen. We're going to quickly find our pen and it's going to be in our hand in a nanosecond. For them, it's more delayed. Their brain actually is sending the message to each one of the body parts that's going to be required to be able to pick that up. And if we've had any structural damage with our brain, it's just going to take it's going to take longer. So we need to be patient with them and give them a little bit more time to process instructions, and then a little bit more time to comply before we determine that they won't do something or that they're non-compliant with us. The next thing is difficulty in self-regulation. It's challenging for them to determine how much energy or reaction is really necessary for what they're going through. So there really are no molehills. Everything is a mountain. They tend to go from 0 to 60 in a nanosecond. And so where we might be able to sense, I'm getting frustrated, I just need to let this go, or I need to breathe or put some of my self-help skills in motion here before I really get upset, they're missing this. Because to them, it feels like that they go from 0 to 60. And we hold them accountable for keeping themselves from getting too upset when this really is kind of a struggle for them. The next symptom is ADHD. And why ADHD here is a symptom is it's different than a true chemical ADHD. If it's a true chemical ADHD and we give them medications or stimulants, we can expect to see a marked improvement. But if it's a symptom, what this looks like, if you're talking to a caregiver, is, well, this was kind of better, but over here, I can't really tell the difference. Or it might be, they were doing better for the first couple of days or maybe the first week, but after that, I didn't see, we couldn't tell they were taking any medication. So generally what happens is the provider says, okay, we're going to up the dose. And then we continue to up the dose until we are at the top of the dosage for their weight. And we're still not seeing that marked improvement. And so we say, well, that's not the right medication. The same medication doesn't work for everybody. So we start switching medications, trying to find that magic medication where we're going to see this marked improvement. And with individuals with prenatal alcohol exposure, we're not going to see that marked improvement because it's a symptom. It's not a true ADHD. Odd eating behaviors kind of ties back into our sensory integration, but sometimes we'll be talking about grazers who eat little bits throughout the day versus eating at meal times, eating only certain food groups, or one of our sons only ate food that was red. It didn't matter when we said, dude, you know, red really doesn't have a taste. If it wasn't red, it wasn't going in his mouth. One of our sons will not put anything into his mouth that he has not smelled and or licked first to see how it tastes or what it feels like in his mouth. So there can be some engorging. Sometimes you go from the grazers who don't are eating light things all day long to the ones who are eating way too much food at a time, and there's a disconnect between their body telling them that they're full, that sensory breakdown. And the last thing on the symptoms that we want to talk about here is the disconnect between actions and consequences. This is extremely problematic. And when we tie this back to high levels of impulsivity and difficulty in self-regulation, you can see that this is just a cocktail that's going to be very challenging for this individual and their caretakers. Just about every system that we have is set up for, I'm going to tell you what my expectation is, and then I'm going to tell you what the consequence is if you don't meet that expectation. And usually when it's not met, there may be a warning. Remember, we talked about this is what's going to happen. Then the next time they're going to get a consequence. And then the next time they're going to get a consequence. And we tend to up the consequences, thinking that when the consequences get severe enough that they'll quit, that this problematic behavior will go away. Or you hear individuals say they don't learn from their mistakes. They just keep doing the same thing over and over again. This is a symptom of prenatal alcohol exposure, that disconnect between the actions and the consequences. And so these individuals are looked at as willfully disobeying and non-compliant, delinquent, etc.
Are there certain chromosomes that are affected that cause the developmental delays?
It's what causes the delay is the prenatal alcohol exposure to whatever was developing at the time of the exposure. They're doing research about the chromosomes right now, and one researcher is hopeful that they're going to be able to duplicate their findings, and it's going to help us along the way. But right now, I can't say to you that for individuals who have an FASD, it is the same chromosome that's affected. What I can say is whatever was developing at the time of exposure is what's going to be potentially damaged.
Thank you. Okay, next question. Is it possible for the FASD to come from the paternal side as well as the maternal side of genes?
This is a really great question. So what we do know, right? We've not done research with humans in the male population because it's unethical and immoral. But we have done research with rats. And so the research we've done with rats is we've not given mom any alcohol, and yet we've given dad alcohol, and he has children. We see in his children some of the same types of challenges, navigating the maze, being easily confused. There's a test that they do where there are styrofoam lily pads, so to speak, I'm not sure what we're going to call those, floating in water, and the rat pups have to get up out of the water onto the lily pad. Those pups have the same struggles and challenges as the ones where mom was drinking. But we cannot say to you that it can come from the dad's side, because we do not have that research in humans to be able to back that up. As you can see across the top here, there is the ADHD, sensory integration disorder, and autism, bipolar. We see these going across the top. And then we see the things down the side that they have in common. So I'm just going to scroll slowly down the side. And this is the PDF that you will get when I get your email address, so that you can have this for reference. And you can see how many times that there is this crossover. So how can you tell the difference between the two? If you do not have the history of the prenatal alcohol exposure, it's going to be pretty challenging for you to tell that this is what it's related to, right? But if you do have the history of that exposure, you can say that you think that it's suspected that it's related to the FASD. Now, that doesn't mean that if you have an FASD that you will never have bipolar or depression or trauma. And especially for those individuals that are coming through our child welfare system, we already know they've got huge ACE scores. We already know that they've experienced separation. We already know that they probably have reactive attachment disorder. And so it becomes very complex, and it's almost like a woven blanket where you're pulling on one thread and thinking that this is what it is, and then a knot erupts, and then you've got another thread. So can we 100% of the time be able to separate these and say this is solely related to prenatal alcohol exposure? No. But we go by history, and we go by what we know, and we do the best that we can as we go through. I think our issue with some of these is, especially with on the autism spectrum, is that there are so many crossovers between the two. And when we don't have that history, this can very much look like autism with all of the sensory integration and the ADHD issues. But when we have that history, we find out that it is probably related to the prenatal alcohol exposure instead. So this goes back to what we were just talking about, the misdiagnosis of many times the first diagnosis these individuals get is an ADHD diagnosis, and then oppositional defiance, because remember, they won't comply versus they can't comply. And then they're often seen in a clinical setting. In our mental health centers, we're seeing them with anxiety issues. We're seeing them with some depression issues. And so they're going to get this diagnosis first. And sometimes we're just plain missing it completely. It's never even been on the radar. And so when there was a study done of individuals, 100 consecutive admissions to a child inpatient, 26% met the criteria for FAS, but had never even been considered before. And then a study with 500 kiddos from 4 to 18 who were in the child welfare system, 30% were given a diagnosis of FASD, and 80% of those had never even been considered before. And so we're going to go pretty quick through these just in the essence of time, but a lot of times people go, how many people are affected, and what are we looking at? So we're looking at, these are real numbers for Indiana in terms of our population and live births for that year. And if we use 2 per 1,000 cases as the multiplier for live births, we would have 164 individuals born that year, and 8 out of 1,000 for ARND, we would have 658. Phil May did a study in 2018 at 4 Midwest cities where they took family histories, they did physical exams, some cognitive testing, and interviewed the kiddos, and they came back with 1 out of 20 school-age children may have prenatal alcohol exposure. Doesn't mean 1 out of 20 will have a diagnosis on our spectrum, but 1 out of 20 could have had prenatal alcohol exposure. Here are our costs. Again, this is what the CD says, about $2 million per person across the lifespan. And in 2010, as a country, 5.5 billion we spent in prenatal alcohol exposure costs. Drinking in Indiana, we say that childbearing years are 18 through 44. We know there's younger and there's older, but out of this population, 45% report drinking and 12.6 report binge drinking. And binge drinking for women is different than men. It's defined as 4 drinks at once or 8 drinks per week. And a drink is 12 ounces of beer, 5 ounces of wine, or 1 ounces of liquor. So when we're talking to individuals about their alcohol use, so most of our alcohol exposure is going to happen in those first 6 to 8 weeks when we may not know that we're pregnant. See, still about half the pregnancies in Indiana are unplanned. So we're still out there living life. We're not thinking about our exposure to salt or caffeine or chocolate or lunch meat or all those warnings that are going out to individuals expecting now. And so we're consuming alcohol. And we go to talk to them about what was their alcohol consumption, how many drinks did they have. We're usually not talking the same language because most people in mainstream wouldn't understand what a definition of a drink is. And they'll say, oh, I just had 1 drink. I went out with my friends at a Mexican restaurant. It was margarita night. We just had 1 margarita. Okay, now think about that for just a second, because if you've been to a Mexican restaurant on margarita night and you've seen the size of those glasses, you already know that we've got more than 1 serving in that 1 glass. And the CDC told us that 1 in 9 pregnant women report alcohol use during pregnancy, and 2.9 report binge drinking. Our barriers to addressing FASD, we're a culture of drinkers. It's all around us. It's in our TV shows and our movies. We can buy alcohol in our grocery store, and we are generally recruiting our next generation of drinkers. And we watch sports with their kiddos on the weekends. And so one of my guys was singing an alcohol, a beer ditty. And I was like, dude, you know what I do, right? And he goes, Mom, he goes, it can't be bad for you because it's on during the day. If it were bad for you, they'd put the commercial on at night when kids couldn't see it. So we're conditioning them that drinking is okay. And when we start putting kings and castles and knights and stuff that are part of our children's play, and when we start making fruity drinks, our fruity seltzers and stuff, that's recruiting our next generation of drinkers. Stigma, when we go back to our example of FASD and autism, if we go into a pediatric office and we're describing the behaviors that we're seeing and we don't know what's causing that, then we're going to be dealing just with the behaviors, right? And then the parents are going to get linked to services and they're going to get a diagnosis that's geared toward what we're seeing. But if we go into that same doctor's office and we say, and you need to know that I drank before I knew I was pregnant, the first thing that's going to happen is that turn and flip, right? So you're the reason why this individual or this child is experiencing these challenges. And so it's very stigmatizing, and we're not creating an environment for this information to be able to be shared. Old messaging, like I said, the OBGYNs are now on the same page with us, but it is taking a long time, and we still hear of OBGYNs telling expectant moms, it's okay if you have a glass of wine now and then, or it's okay to do light drinking. So we're still butting up against old messaging. We're not doing universal screening, pre-delivery, and certainly not doing developmental screening for FASD or prenatal alcohol exposure after birth. Data collection, lack of infrastructure, silos, all kind of go together. There is no single entity in the state of Indiana that is collecting this data. So when I'm giving a training, I may have a classroom teacher say she's got 2 kiddos in her class. I maybe have someone who provides mental health services or a case manager for a waiver, and they're all going to say they have these individuals on their caseloads, but there's no one source that knows of all of these places where these individuals are that's collecting the information, and then funding, right? So right now we spend a lot of money in our illegal substances, not so much here. Life expectancy, we have seen a length in this life expectancy, but we've got no study to replace this one. So this is still kind of our standby. It was done in Canada, and the average lifespan is 34 years for someone with FAS. Now that's the most severe, and that's due to external causes, risky decision-making, that lack of being able to connect those choices and consequences. If I jump off the roof, what could potentially happen to me? If I play with this knife, if I do this, you know, what are the potential outcomes for this? And this also includes a 15% suicide rate. There was a study done with adolescents, ages 13 to 18, 54 of them. 35% reported suicide ideation, and 13 had at least one serious suicide attempt in the past year. The average age for someone with an FASD to come into contact with law enforcement or our justice system is age 12.8. Going back, remember that impulsivity, that not thinking through, that failure to connect choices and consequences is going to be a challenge for our individuals. And many of our youth are going to be in trouble with law enforcement. Now, it can be due to just what we just said, that risky decision-making or that disconnect, but this also has to do with that difficulty in self-regulation. So if we have a youth that has a hard time balancing these big emotions and is having outbursts, is having meltdowns, and they turn aggressive or they turn physical, we're gonna see them, they're gonna show up here. 50% of individuals with an FASD will have a history that includes confinement, whether that's jail, prison, chemical treatment, whether that's inpatient or residential. And for them, they are at high risk for using substances or alcohol more than their peers, if that's even possible in today's challenges for our peers. And it tends to escalate to addiction much quicker than their peers. So here is my contact information. When you get a copy of these slides, it will be there. Here's our website. We have lots of information on our website, and we're on Facebook and Twitter and Instagram and all of those that are now part of the social media regime.
So it's really about timing, as in when mother's drinking, how much, potency, frequency, and then the developmental period during the pregnancy when that drinking is happening, essentially.
Yeah, it can happen. Damage can happen any time throughout that. But when we think about, especially the brain, the very first part of the brain that develops is that brain stem. And that's all about all that stuff that we can't control. You know, all of our systems, our survival systems. And so when that's damaged, and then the last part, especially with regard to the brain, when that prefrontal cortex, that command center, that ability to weigh consequences, we see a lot of challenges with that prefrontal cortex that comes about.
So Kate said the life expectancy was shocking. Tom said this was incredible. Thank you. Natalie said this was great. Deirdre said very helpful and informative. And then Susan, it looks like Sean said this was a very good seminar, answered questions about a kid I used to help, and everyone was asking me, why is it that nothing seems to work?
I think because when we're dealing with memory, remember the short term and the issues with the memory. When we're dealing with the memory, it becomes complicated for it to work. We say that it may work one day, but it may not work the next day. So it's just important to equip our caregivers with multiple tools so that they can try one thing and then try another. And then I think because how complex it is, it makes it really hard. And it's not that we don't see improvement. And it's not that, you know, if we had more time together, we would talk about appropriate consequences. It's not that when we're parenting or caring for individuals with prenatal alcohol exposure, we don't give consequences. It's that we start really looking at those consequences in terms of what's natural, what's logical, and what's teachable. And too often, the kind of consequences that we give are punitive and they're general in nature. You're grounded, you know, you have 2 days in school, you're suspended, what does that have to do with leaving the bike out in the driveway? You know, you leave the bike in the driveway, the natural consequence is A, it gets stolen, or B, a car gets backed over. And the logical is, hey, I'm really sorry that the bike got left in the driveway. We're going to leave it in the garage for tomorrow. We'll try again the next day, having the bike out. And it's directly related to something that's teachable. And then we do it over and over and over and over so that they know that we're being consistent and we start forming those new pathways. But most of our consequences in parenting and in institutions and education are not really geared toward being natural, logical. They're just all about, I want this behavior to stop. What's the most expedient way to make it stop? Boom, here's your consequence. So
thank you all so much. Thank you, Susan. This was incredible. This was super enlightening. I can tell you that I learned a lot. And I know based on what we saw in the chat that people are so thankful. Thank you all so much and have a good one.